Hello and welcome to the Multiple Sclerosis Association of America's live webinar, Managing Depression and Anxiety in MS. I am Peter Demiri, Senior Director of Content Development for MSAA and your host for tonight's program. On behalf of MSAA and our guest presenter, Dr. Amy Sullivan, we thank you so much for joining us tonight and hope everyone is doing well and staying safe. As you may have read in our recent announcements, March is recognized as MS Awareness Month, and MSAA's theme this year is Improving Mental Health and Wellness, a very important yet often overlooked topic in MS care, especially as we continue through this pandemic. Tonight's program continues our series of digital educational events on this topic, which also includes a podcast with Dr. Sullivan on caring for the care partner, an archived webinar on finding purpose in life presented by Dr. Adam Kaplan, and much more. All of this great content can be found on our dedicated MS Awareness Hub at mymsaa.org. Also, tonight's program continues our new virtual display hall, which is mentioned in the chat box with the link. This online resource details some of the products and patient assistance services offered by our selection of sponsors. MSAA would like to thank Biogen, Genentech, and Sanofi Genzyme for taking part in this new virtual opportunity. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. Listed here are just some of our many free programs, including our cooling, equipment, and MRI programs, along with our COVID-19 and MS Pathfinder tool, which provides ongoing updates on the coronavirus and the recently approved vaccines. Also, please know MSAA has extended our helpline hours to 8 p.m. Eastern between Mondays and Thursdays. To learn more, please visit mymsaa.org or give us a call at 1-800-532-7667. And finally, please note tonight's webinar will be archived to our website within a few days. For the Q&A session, please type your questions into the chat box on the screen and we'll address them at the end of the presentation. Also, if you're having any technical issues, please type your concerns into the chat box as well. At this time, I am extremely honored to introduce our special guest presenter, Dr. Amy Sullivan. Dr. Sullivan is a board-certified health psychologist and Director of Behavioral Medicine Research and Training at the Cleveland Clinic's Mellon Center for MS. She is passionate about physician self-care, burnout, diversity in leadership, and psychological health. Her clinical interests focus on individual, family, and group work with patients and family members affected by multiple sclerosis. Dr. Sullivan, thank you so much for being here tonight and helping us learn more about this very important topic.
I'm so thrilled to be here tonight, Peter, and with all of you on the phone today. It's such a strange world that we're in, and I think we're all starting to get used to these Zoom type of meetings, and so I just appreciate the opportunity to be here today. So today I am going to be talking with you about mental health, and this is definitely my passion. I've spent the last 10 years of my career in the Mellon Center for MS at Cleveland Clinic, and my clinical specialty is solely focused on MS care. Specifically caregiving, depression and anxiety and adjustment disorder for the MS patient. So if I were with you in person today, I would love to do this next experience with you, but I'm not. So what I'm going to have you do is I'm going to have you look at this person with MS. And in your head, I just want you to think about who this person is. Describe this person. So this person has MS. What are some of the adjectives that you would put onto this person? How does this person feel? And just take a moment and think about that in your head. So again, if I were with you in person, you would be shouting this out to me in a room, and many of the things that you would shout out would be things that are invisible symptoms. So possibly the person experiences depression or anxiety. Possibly fatigue, maybe some relationship issues, maybe some cognitive symptoms, maybe some pain, insomnia, maybe even sexual dysfunction. So when we think about invisible symptoms, I think it's important to point out that sometimes these are the most debilitating symptoms of a chronic disease, in particular MS. So let me give you some statistics here. So with regards to fatigue, the way that it's been described to me over the past 10 years in my clinical practice is the MS patient will say, it's like having a 24/7 flu, constant fatigue. The literature tells us that about 90% of our patients have some form of fatigue. When it comes to cognitive symptoms or cognitive complaints, between 40 and 65% of our MS patients will experience some sort of cognitive complaint. This specifically affects processing speed, and what we know about the cognitive symptoms is that depression may exacerbate these symptoms. So again, very important to pay attention to symptoms of depression and managing those. Pain is prevalent in up to 86% of our patient population, and sexual dysfunction occurs in up to 64% of our patient population. So things that are oftentimes the most debilitating are these invisible symptoms. So I'm going to introduce you to a patient of mine. Of course, all identifying information has been changed, and actually this is a collaboration of several different patients. So I'm going to introduce you to Sarah. So Sarah is a typical patient that would come to my practice. She's 31 years old, married. She's the mother of 2 small children. She's a full-time labor and delivery nurse from Pittsburgh. She was diagnosed with relapsing remitting MS 6 months after the birth of her first child. Sarah describes weakness in her left arm daily. She has vision issues, describes severe fatigue, has incredibly high expectations of herself, has significant anxiety and feelings of frustrations and inadequacy. She describes physiological symptoms of anxiety, such as racing heart, and she describes some cognitive symptoms of anxiety, such as ruminating negative thoughts and feelings of hopelessness. To cope with these anxious feelings and these feelings of inadequacy, she frequently overuses benzodiazepines and wine. Sarah's main complaint to me is that she's upset that people cannot see her disease, so a lot of invisible symptoms. And people expect that she acts like a healthy person, quote unquote. 6 months into her MS diagnosis, she continues to have worry and anxiety and is having difficulty sleeping and having adherence issues with her treatment plan. This is a very typical patient that we would see in the Mellon Center. I want to share with you a poem that was written by Emily Kingsley, and I think you're going to understand why I share this poem with you, but this may have been a similar experience for you when you were newly diagnosed. So here's the poem. When you plan your life and meet your significant other, it's like planning a fabulous vacation to Italy. You buy a bunch of guidebooks and make your wonderful plans. The Colosseum, the Michelangelo David, the gondolas in Venice. You learn some handy phrases in Italian, and it is all very exciting. After months of eager anticipation, the day arrives where you pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say? What do you mean, Holland? I signed up for Italy. I'm supposed to be in Italy. All of my life, I dreamt of going to Italy, but there's been a change in the flight plans. They landed in Holland, and therefore you must stay. The important thing is that they haven't taken you to a horrible, disgusting place. It's just a different place. So you go and you buy new guidebooks, and you must learn a whole new language, and you'll have to meet a whole new group of people you would have never met. It's just a different place. It's slower than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills. Holland has tulips. Holland even has Rembrandts. But everyone you know is busy coming and going from Italy, and they're all bragging about what a wonderful time they had there. And for the rest of your life, you will say, "Yeah, That's where I was supposed to go and what I had planned to do. And the pain of that will lessen, that you understand that you lost a significant dream. But if you spend your time mourning the fact that you didn't go to Italy, you may never be free to enjoy the very special, very lovely things about Holland. And again, this was written by Emily Kingsley, and it was written in response to the fact that she had a developmentally disabled child. And so she had planned all of her life what she thought her life would look like, and it changed. And she learned how to see the very beautiful things about the life that she now had versus the life that she had expected. And I imagine that this is very similar from a very similar experience from what many of you have had as you've been diagnosed with MS, adjusting the expectations and adjusting the life that perhaps you're mourning. So let's talk a little bit about the patient experience. So chronic disease is amongst the most common and costly conditions in the United States. Staggering statistics here, at least when I was looking at them from the CDC, I had no idea. But these are statistics from the CDC, which reports that about 50% of all adults have at least one chronic disease. 30% of 18 to 44-year-olds have a chronic disease. So the young population, right? Now, what we know about MS is it's usually diagnosed around that time frame as well. 1 in 4 adults have 2 or more chronic diseases, and 7 of the top 10 causes of death are chronic disease. The overall estimated cost is $2.5 trillion annually. And one of the things that we know is that wellness and preventative medicine can decrease these numbers. And one of the other things we know is that chronic disease is very uncertain, as I'm sure you can all address with your own MS. So let's talk about depression. Depression is highly prevalent in chronic neurological conditions such as multiple sclerosis. It may contribute to significant morbidity issues, decreases in quality of life, disability, decreases in adherence to treatment. When we're thinking about treatment, we have to think about treatment from a holistic standpoint. So this is not just decreases in adherence to DMTs. This is decreases to adherence of all treatments, so speech therapy, psychological therapy, PT, OT, etc. Can also cause apathy in treatment decisions, so slower treatment decisions, cognitive complaints, relationship stress, and unfortunately suicide. Depression is one of the most common symptoms of MS, but it's also one of the most treatable symptoms of MS. I wanted to share with you some of the prevalence rates of MS versus the general population. So when you're looking at this graph, the left-hand bar graph in each, the dark blue, is the MS population. And then that teal to the right is the general population. And so what's important that you see here is that the MS population has prevalence rates of depression at about 3 to 4 times that of the general population. Anxiety, you see, is elevated. Anxiety is a very difficult thing to measure. One of the reasons is because it's difficult to tell if a person is experiencing a state of anxiety or a trait of anxiety. So are they experiencing a moment of anxiety, or is this more of a personality, anxious personality? Adjustment disorder, as you can tell, about 10 times the amount in the MS population. Bipolar disorder, we have 13 to 4.5%, and then psychotic disorder is about 2 times the amount. So important for you to just kind of put this in your head so that you know how prevalent mood disorders are in the MS population. When we look at chronic disease challenges, I think it's important that we always remember that invisible symptoms are so very, very difficult to deal with. As we had said earlier, with the case of Sarah, many people look at somebody with a chronic disease, with multiple sclerosis, and they say, but you look fine. You're not losing your hair. You don't have a cast on. You're not walking with crutches, etc. Something that they could see. Many of your symptoms are they're the invisible symptoms. The challenges also are that you have to make difficult treatment decisions. So some of the DMTs come with difficult side effects, and you have to weigh the risks and the benefits. You have to decide if you want to make difficult disclosure decisions. So For example, if you're newly dating somebody, do you disclose that you have MS? Do you disclose to your boss that you have MS? And then if you choose to disclose, how do you deal with the reactions of others? I think it's also important to learn how to communicate limitations and needs. It's very important that you're able to say that, if you're having a day where you're not feeling well, having extreme fatigue, and you don't want to go on that 2-mile walk, that you're able to say, yeah, I'm just not in the mood for that. Or if you need some help with something, you say to your significant other or family member or friend that you might need some help, and that's very difficult to do. And then it's important to plan for uncertainty. So financial planning, estate planning, disability, insurance policy, SSTI. So when we think about the dynamic challenges of the chronic illness, one of the first things that comes to my mind is what we see in families, which is this role reversal or this identity shift. And what that can look like is their everyday life changes. So a spouse that was once at the office is now coming home and is staying at home. A child who, was a 9-year-old and having, just playing outside all the time is now, they now have expectations of helping at home. This can also look like emotional reactivity. So it can look like a bunch of different emotions. So what you see there to the right are the stages of grief from Kubler-Ross. And so one of the things that I want to point out is that the stages of grief are not linear. They, each person kind of goes into the stages of grief at their own time and with their own emotions. And so at one point somebody could experience depression, and then they could be angry, and then they could deny that this is happening, and then they go back to depression. It's not a linear model. And so there are a number of different emotional side effects or emotional symptoms that one may experience. And it's just important to put those all out there so that you're aware of them. So let's look a little bit at collaborative medicine and why it's important to have emotional support involved with your overall MS care. And so I'm going to start by sharing with you the parable of the blind man and the elephant. And this is an Indian fable that tells of 6 blind men that come across different parts of an elephant in their life's journey. Each man creates his own version of reality from his own limited experience and perspective. And so let me share it with you. There were a group of blind men from Hindustan, and they heard that a strange animal called an elephant had been brought to the town, but none of them were aware of its shape or form. Out of curiosity, they said, "We must inspect and know it by touch, of which we are capable." So they sought it out, and when they found it, they felt it. In the case of the first blind man whose hand landed on the trunk, he said, "This thing is like a thick snake." For another one whose hand reached its ear, he said, "It's like a fan." As for another person whose hand was upon its leg, said, "The elephant is a pillar-like tree trunk." The blind man who placed his hand upon its side said, "No, the elephant is definitely a wall." Another that felt its tail described it as a rope, and the last felt its tusk, stating that the elephant is what is hard, smooth, and therefore it must be a spear. The 6 men fell into this great argument about the nature of the elephant, and they all called each other crazy because they each held the true elephant in their own hands. But because they never valued each other's opinion, no one ever understood that the elephant that they began to argue about, in fact, was right. It looked as though they were getting agitated. A wise man was passing by and he saw this. He stopped and asked them, "What is the matter, men?" They said, "We cannot agree to what the elephant is like." Each one of them told what he thought the elephant was like. The wise man calmly explained to them, "Well, in fact, all of you are right. The reason every one of you is telling it so differently is because each of you touched the different parts of the elephant. So actually, if you look at the elephant as a whole, it has all of those features with what you said. You just need to put it together." I love this because to me this speaks about collaborative medicine. What I take away from this is that to move forward in collaborative medicine or interdisciplinary medicine, we need to value the perspective of others while holding true to what we understand ourselves. So from my perspective, I understand the brain and mental health and emotions very, very well. But I work closely with nursing, with primary care, with neurology, with emergency medicine, with PT, OT. And all of us bring our own unique biocentric approach to the patient and to the medical team. And I think it's important that we learn how to hear each other's perspectives. So this is a picture of our interdisciplinary team at the Mellon Center. The patient is always at the center of the team. And the patient is touched by all different disciplines, and we respect and we honor each one of those disciplines because each one of those disciplines plays an important role in the patient care. I also want to explain to you how important worldview is. So worldview, I think, is a very important concept to understand. Worldview is basically the fact that each person comes into any experience with their own existential, fundamental, cognitive orientation of the world, a microcosm, a culture, a group of people, etc. Worldview is likely very diverse in nature. Thus, in interactions with others, we ask that each person is open to evaluating their themes, their values, their emotions, and cognitions in a non-judgmental way. We ask that they're open to hearing other people's processes and understanding where others come from. And this kind of goes back to the parable of the blind man and the elephant, where we all see the world through our own lens and our own experiences. So with the biopsychosocial model of care, which is what I just showed you, it helps us to guide the patient and see the patient as a complete picture, honoring what each specialty brings in. We're all biological, psychosocial, social creatures, and all of this needs to be addressed. So when I think about my practice, I think about the top 3 things why one would come to my practice. And like I said, I've been in this field for quite some time, and so these are the top 3 things that we deal with: anxiety, stress, and depression. So let's talk a little bit about anxiety. Anxiety is common, but it's frequently overlooked. What we know about anxiety is that it usually comes hand in hand with depression. So when somebody has depression, we should always be looking for anxiety as well. There are several subtypes of anxiety: generalized anxiety disorder, obsessive compulsive disorder, panic disorder, specific phobias, PTSD, and adjustment reaction. There's less attention paid to anxiety in the literature than there is depression. So adjustment disorder is the development of anxious or depressed symptoms in response to medical symptoms or disease that occurs within 3 months. Adjustment disorder is characterized by marked distress and significant impairment in social or occupational functioning. And the treatment is that we normalize, we empathize, we provide education, stress management techniques, and at times medication. I also think that the 3x3x3 rule is incredibly important in describing adjustment disorder. And so what that is it's, you could see me right now. I have my hands up in front of my face as blinders. So the first 3 weeks of the diagnosis, the MS disease is kind of right there in front of your face. It's like the only thing that you think of. And then by 3 months, it kind of moves out to the periphery. You can still see it. It's still a very prevalent thought. You're still able to, you're still seeing it very often, but you're also starting to think about other things. And then by 3 years, as you could see, my hands are kind of by my ears right now, because what that means is it's still there. It's still something that, is there. You know you have it, but it's not the thing that you think about all of the time. So I love the 3x3x3 rule because it helps you to understand the time it takes to adjust to a new diagnosis or perhaps functional decline or a shift in diagnosis, whatever the change may be. So let's talk about stress management. One of the things that I can't leave out is the fact that we are in a pandemic. And what you will hear me say over and over and over again is we're not only in a physical health pandemic, but we are in a mental health crisis right now. I've never seen my practice as full. I've never seen the severity of symptoms like I'm seeing right now, and for the past 12 months actually. As it's just been this, this mental health crisis that we're in. And so I wanted to spend a few moments just to talk about what that looks like. So when we think about our emotional health during the pandemic, there are waves of emotion, there's an uncertainty, there's an influx of information. Sometimes we don't know what's right information, what's correct information, and what's incorrect information. There's more social distancing than ever to keep us safe, but that certainly creates isolation, loneliness, can create some anxiety and depression. And for many, there's economic uncertainty. This all leads to decreases in well-being and psychological health and increases in uncertainty, depression, anxiety, and stress. Speaking of stress, let's look at the effects of stress on the body. And I really love this slide because it shows you that stress does not only affect you from an emotional level, but stress plays an important role in all of the major organ functions in the body, organ systems in the body. So everything from the brain to the cardiac system, to the immune system, to the GI system, to sexual system, to your bones and your joints. Stress plays a major role on our body. So it is not just the mind. There is a mind-body connection, which we will talk about later in this presentation. So what do we do at Mellon Center for stress management? Well, we've developed a 4-session stress management protocol where we teach skills of education, cognitive behavioral therapy, and breathing skills. It's very short term. In fact, our outcomes data shows us that within 3 sessions, our patients are actually seeing significant decreases in anxiety and depression. And the most important thing is that we do this every 4 to 6 weeks. So we spread our sessions out every 4 to 6 weeks because we want to teach our patients the skills. And of course, if they do it perfectly in our office, it doesn't matter if they can't do it perfectly outside of the office, right, or even sub-perfectly outside of the office. So what's important for me is that I teach them the skills and that they then apply them outside of the office, and then they come back with data in terms of how they were able to utilize their stress management skills. And finally, let's look at depression. So when we think about depression, what we know is that it's one of the most common symptoms of MS, but it's treatable. It's oftentimes difficult to distinguish between symptoms of depression and symptoms of multiple sclerosis. And in our next slide, we'll talk a little bit about that. It does differ from normal grieving. Symptoms are usually more irritability than tearfulness, and I've seen that over and over and over again in our MS practice. Oftentimes, even the care partner will say to us, it's like walking on eggshells when I'm with my partner. A lot of irritability, and very infrequently is there tearfulness. It's more common in females than in males, but the strength is greater in males. We also know that stressful life events are the strongest predictor to developing a depression. So, for example, an MS diagnosis, an MS progression, and then there are a ton of other life stressors that can occur there. We know that individuals with chronic disease, specifically MS, are at greater risk than the general population. And remember that prevalence slide that I showed you earlier, which shows that depression is about 3 to 4 times as great in the MS population than in the general population. We know that cognitive decline or cognitive complaints can be linked to depression and anxiety, and depression and anxiety may exacerbate cognitive complaints. Depression is also a predictor for slower processing speed. And this statistic is the one that really shakes me the most, and that is that the suicide rate is 7.5 times higher than in the general population. So these are the symptoms that one must have in order to be diagnosed with major depressive disorder. So I guess what I'll say before we cover this is, if you remember that prevalence slide, so it showed that up to 54% of patients may have a depression. These are people who are diagnosed with this disorder that you're looking at here on the screen. There are others who have symptoms of depression that are not included in that prevalence data because that's the diagnosable disorder, okay? So what you'll see is that it takes a lot to be diagnosed with major depressive disorder. So what we're looking at here is that one must have at least 5 or more of the following symptoms nearly every day for at least 2 weeks, one of which must be sadness, or what we describe as irritability in this population, or loss of interest in things that they once enjoyed. Also, we see symptoms of guilt, we see loss of energy, we see loss of concentration or cognitive complaints, loss or increase of appetite, psychomotor agitation or retardation. We see sleep problems and suicide. Again, you all know that many of the MS symptoms overlap with some of these, and so that's why it's important to have a behavioral health clinician or mental health clinician be able to confirm or deny that a person has major depressive disorder and get them the right treatment if they do. So here are some treatment decisions. So first and foremost, we use a therapy called cognitive behavioral therapy. We'll focus more on that in the next slide, but I just wanted to mention it here that it is understanding the connection between thoughts and mood. We've talked about Kubler-Ross's theory already when I showed you the diagram of the different emotions. So this is the grief, acceptance, and in my practice, we like to call it the adaptation model. I don't necessarily agree with acceptance. I think people get to a point where they say, oh, I guess I just accept it. That's very passive to me. I would like for people to get to a point where they realize that not only do they accept the fact that they have multiple sclerosis and they may have some limitations, but that they adapt their life to still live the best life that they can. We do behavioral therapy, which are some of the things that I was sharing with you about the stress management protocol, so different types of breathing skills, and I'll do one of those with you later in the session. We do group therapy. So at the Mellon Center, we're very fortunate to have a large behavioral medicine team, and we do several different groups. We have 6 actually in the Mellon Center. We have a young professionals group, a caregiver support group, a men's MS group, an MS support group, a neurocognitive group, a sleep and fatigue group, and then we also do several shared medical appointments with our neurology team for the newly diagnosed patient. There are also a lot of community support, such as MSAA, Facebook groups, etc. So I thought that it was important to spend a little bit of time looking at cognitive behavioral therapy. So cognitive behavioral therapy focuses on the relationship between thoughts, emotions, and behaviors, and how emotions interact with all, and helps to formulate the mood. So it's relatively short in duration, about 6 to 16 weeks. There are different modes of delivery and can be delivered via telemedicine, which we've really learned this year how to use pretty effectively, and for that I'm very, very grateful. We can incorporate relaxation, stress management, breathing, visualization, and mindfulness-based interventions, and it can also be delivered in group format. So it's a highly effective form of psychotherapy, and as I shared with you earlier, our outcomes show that with only 3 sessions, people are experiencing significant decreases in both depression and anxiety. But I will spend just a few moments looking at pharmacotherapy classes. So the first line would be the SSRIs for first line of treatment for anxiety and depression. Important to make sure that your doctors know everything that you're taking, because there can be potential medication increases or interactions, and then some side effects. The second line are the SNRIs, and these are typically recommended for people who have pain and depression and anxiety. And then the third line would be benzodiazepines, and they're not used as often because they can become addictive and habit-forming. I'm going to give you Coping with Stress, my Fast 5. So first, wellness is imperative. When we think about wellness, we're looking at all of the pillars of wellness, right? We're looking at activity, we're looking at healthy eating, we're looking at rest, recharge, recover, so maintaining those healthy diets, moving, having a routine, incorporating spirituality if that's important to you, having a well-being approach, and sleep. Number 2 is taking a break from media. So disconnecting from media, staying informed from a trusted source. So having one 30-minute block in the morning and one 30-minute block in the afternoon or PM, and that's about it. We really have to protect our children and our elderly from incorrect information, and we have to provide age-appropriate information to our children. This rest and recharge is so very, very important. So this is about shutting down that sympathetic nervous system or that fight or flight response and turning on that rest, recharge, recover. So in order to do this, we need to sleep, we need to rest. So therefore, it's important not to watch news outlets within an hour time frame of going to bed if they rev you up. Limit stimulants, alcohol, and nicotine before bed. In some cases, limit exercise as well because it can stimulate you. It's important to stay on your normal sleep-wake cycle. So on the weekends, not varying too much from that. I always recommend worry journals to people who can't shut their minds down when they lay down for bed. Have you ever noticed that when you're lying on the couch and you're watching a movie with your family, it's so easy to conk out. But when you go up into your bedroom and there's nothing on, there's all it is are your thoughts that are playing through your head, it can become very difficult to fall asleep. And so in this case, we recommend a worry journal. And then perhaps it's important to come up with a wind down routine. So maybe a bath, a cup of tea, some prayer, some meditation, whatever that looks like for you. Number 4 is connecting with others. So reaching out to family, friends, and colleagues, one of the best ways to overcome burnout is to connect with others, particularly connect with those we know that are isolated, perhaps sending a card, setting up FaceTime, Skype, etc., just becoming creative and connecting safely. And then finally, doing some stress management techniques. There are lots of them, and it's not a one-size-fits-all. So breathing techniques, visualization, mindfulness, but what's important is that you seek mental health help if you notice that worries, anxiety, isolation, etc., are becoming unmanageable. So I get this very often. People come into my office and they say, so doc, are you telling me this is all in my head? So let me tell you a little bit about Descartes and mind-body dualism. So Descartes believed that there was a disconnect between the mind and the body. His belief was that the mind is non-physical and that the body, which is physical, is distinctly separate. His theory of mind-body dualism separated the mind and the body, and many philosophers have since described arguments against this theory. But it's important to understand the original belief of the mind-body separation in order to understand the mind-body connection, which is our understanding now. This understands that a person's thoughts, feelings, and behaviors relate to their physical symptoms. So let me show you an experiment where maybe you'll buy into this. So I want you to imagine that prior to me coming here today, that we're all in the same room, and that I have a cutting board, and I have some lemons, and I have a very sharp knife, and I'm just going to slice those lemons, and they're oozing with juice. And I'm going to hand each of you a piece of my lemon. And what I want you to do is I want you to take that lemon, put it in your mouth, and bite down on it. Notice what's happening in your body, if there's a physiological reaction. Next, imagine that I have a roll of aluminum foil. So I'm going to tear a piece of aluminum foil, and I'm going to give it to each of you, and I'm going to ask you to put your fingers in it, crumple it up, and again, put it in your mouth and bite down in it. Just, again, notice what's happening to your body. Next, if you're like me, you come home and there's all these Amazon packages lined up at your door, and inside of your Amazon packages are usually styrofoam. And so what I want you to do is I want you to take that styrofoam and break it apart, stick your fingers in there, probably screeching some when you stick your fingers in there. I want you to take it, again, put it in your mouth. Finally, imagine that there's a chalkboard in the room and I'm standing right in front of you with this chalkboard, and I scrape my nails down that chalkboard. So what I am imagining, and again, I'm not in the same room with you. I'm probably not even in the same state with you. You can't see me. But what has happened is that without you even experiencing the stimuli, without you even seeing the stimuli, you're likely responding to that stimuli in a physiological manner based on a memory, right? So you know what it feels like to put a lemon in your mouth, and your body probably is salivating from that. You're probably cringing with the thought of the aluminum foil and the styrofoam. And you're probably tensing up with the thought of my nails going down the chalkboard. All of this is the mind-body connection. We respond physically to a memory or an experience that we once had. So does this actually work? So now what I'd like to do is I would like for you to engage in this breathing exercise with me. So what I'm going to have you do is I'm going to have you just get in a comfortable position and just breathe. So I'm going to time you for 1 minute, and I would like for you just to count your breaths and breathe. Okay, ready? Begin. Okay, stop. So I want you to think about a couple of things. First and foremost, what were the thoughts that were going through your head? Were you thinking, this is the longest minute ever? When is this going to end? Or are you thinking, this is actually really nice to have a minute to focus on myself? Neither of which are the right thoughts. It just wants you to be honest with what you're thinking. The second thing I want to know is, it's so hard to not have an interactive audience, but the second thing I want to know is if you had greater than 6 breaths per minute, okay? So my goal is for people to have 6 breaths per minute or less, but I guess I'll take up to 12 because of this. What we know about hyperventilation in the field of psychology is breathing more than 12 breaths per minute. So the average person breathes 2 times the normal level, which causes lower brain oxygen levels. Hyperventilation reduces oxygen delivery to all vital organs in the body. And what you're seeing here is that it reduces oxygenation to the brain as well, which can cause several problems, right? It can cause concentration difficulties, cognitive difficulties, stress, anxiety, etc. So what I'm going to do now is I'm going to talk to you a little bit about diaphragmatic breathing. So diaphragmatic breathing. So the diaphragm is this large muscle located between the chest and the abdomen. And there's a lot of lymph nodes located just below the diaphragm. So that green upside down U is the diaphragm. There are a lot of benefits to diaphragmatic breathing. It improves the venous return to the heart. It leads to improved stamina in both disease and athletic activity. By expanding the lungs' air pockets, it improves the flow of blood and lymph. It helps prevent infection of the lung and other tissues. It increases oxygenation in the body, and it's an excellent tool to stimulate the relaxation response that results in less tension and an overall sense of well-being. So diaphragmatic breathing is really learning how to pull that breath from our chest, which is where most of us breathe, into the diaphragm. People who are really good at diaphragmatic breathing are people who have played wind instruments, are in choir or sing, who are endurance athletes, are people who practice yoga on a regular basis or mindfulness on a regular basis. So what I'm going to do is teach you how to get 6 breaths or less in 1 minute. So this is a way of breathing that I created called serial 3 breathing or circular breathing. And what it is we start on the inhale, but we do a slow, steady 3-second breath in. So it would be 1, 2, 3. And then you hold your breath for 3 seconds. 1, 2, 3. And then you exhale for 3 seconds. It's 1, 2, 3. So we're again going to practice this skill that you can take with you, and this is the last thing that we'll do today before we take questions. But I wanted to leave you with some tools of relaxation and stress management that you could use outside of here. So again, I'm going to time you for 1 minute, and I want you to follow this pattern. So I will walk you through the first cadence, and then I want you to go through your own cadence, as mine may be more different than yours, or a different speed than yours. And I want you to count. So your 9-second breath, all the inhale, the hold, and the exhale, would be 1 breath, okay? So we're going to start now. In, 2, 3, hold, 2, 3, out, 2, 3. Go ahead and take over. Okay, stop. So in my experience, you probably were able to focus more on this breath because you didn't have the ability to distract with your thoughts because you were focused on the continuation or the circular 3 breathing. And so that's a wonderful thing when we can be mindful and in the moment. So this is a form of mindfulness meditation. I would also assume that most of you got 6 breaths or less. And perhaps some of you even got fewer than 6 breaths or less. So when people become really good at this, they turn this into a square. And what I mean by that is that they start the inhale, they hold, they exhale, and then they hold again. And so typical normal breathing is in, out, and that's not a way to stimulate the relaxation response in our body, but the hold is. So the hold is magic. The more you can practice or participate in the hold of breath, the better and the more relaxed you'll be. So I hope you enjoyed those. We are at our summary section, and knowing that this is, mental health disorders are very common yet very treatable conditions. Remembering the parable of the blind man and the elephant, that all medical specialties work together to understand the entire patient, including the high prevalence of mental health disorders. And the treatment of mental health disorders is a necessary component of patient care and leads to better outcomes and quality of life. So we are at our question section, and unfortunately I was not able to keep up with the questions, and so I'm going to ask Peter if you can give me some of those questions, and I'll answer those for the next 10 minutes.
Sure, absolutely. Thank you again, Dr. Sullivan. Excellent presentation. Well, we did have quite a few questions that came in, and several questions were around understanding the difference with anxiety and depression and MS. Are anxiety and depression caused by MS, or do people just struggle being anxious and depressed because they have MS?
Yep. So it's what came first, the chicken or the egg, and that is a very common question that I get in my practice. yes, anxiety and depression are both caused by MS and a reaction to MS. So to me, it doesn't matter where the anxiety or MS came from. What matters the most is that we treat it. So if you're experiencing anxiety or depression, it's very important to seek care because what I say very frequently is MS steals so much from us. Don't let it steal your joy.
Excellent. Thank you. We actually had a special guest attending this webinar, which is Dr. Adam Kaplan, who presented earlier on our purpose in life, and he posted this question. How do you deal with the stigma that surrounds mental illness, both with patients and care providers?
Dr. Kaplan, thanks so much for joining today. I was just sharing with somebody just today, actually. They asked, whose research will I always follow? And I mentioned you as that, so it's just an honor to have you here today. So my whole Twitter handle, so if anybody's interested in following me on Twitter, it's at Dr. Amy B. Sullivan, is about normalize and not stigmatize. Why that's important to me is because I trained in New York and in Atlanta. In New York and Atlanta, your therapist is kind of like they live with you on your shoulder. Their thoughts are with you constantly. And then I was recruited to the Cleveland Clinic, and I realized, boy, there's quite a stigma here in the Midwest. And so my goal has been really to destigmatize mental health. And so I think we've done a really exceptional job of that at Mellon Center because what we have done is within the first session, so the first time a person has been diagnosed with MS, they're offered one of our shared medical appointments. And in that shared medical appointment is the neurology team and my team. It's so important that we destigmatize and just make it a normal part of care that we've put ourselves, well, Dr. Bermel has put the behavioral medicine team into the first initial appointment. The other thing that we do is we talk about our services in terms of stress management. So sometimes it might be scary to hear the word bipolar disorder, or it may be difficult to hear the word depression, but I think people hear the word stress constantly, and so we've really kind of made our bread and butter based on our stress management tools. And so we've worked very hard to normalize and not stigmatize mental health, and hopefully we will continue to do that over the course of time. So thanks, Dr. Kaplan.
Yeah,
I do see one,
very good.
Sorry, go ahead, Peter.
No, go ahead.
I did see one question in here that I wanted to address. So I'm just reading the very end. I'm so sorry if I'm not going back to the beginning, but there was a question in here. Somebody had asked about breathing and it made you lightheaded. Betty asked this. I'm very appreciative that you brought that up. So if I were teaching this in my office, Betty, I would say it's normal to get lightheaded if you don't typically breathe this way. But it's scary to get lightheaded. So I would have people stop the breathing exercise if that was happening, and then start again, and then gradually make small improvements in breathing. Again, like I said, many people who are wind instrument players or people who are singers or people who are endurance athletes, they know how to do that diaphragmatic breath, and they probably breathe 6 breaths per minute or less on a given day. But most of us don't do that. So I can tell you from my experience that happened to me as well when I first started doing this, even though, I'd been an athlete my entire life and I've played the flute my entire life. So it still made me lightheaded. And so what I did was I gradually started incorporating this. But now, patients will say to me, can you show me what it's like to breathe inappropriately so they can see it? And I can't even do that anymore because I've learned how to use the diaphragmatic breath.
Great. And a similar question on breathing. Do you believe breathing is a key in managing anxiety?
100%, yes. I think we have to learn. So what ends up happening from a physiological standpoint is if we do these choppy chest breathing, we're not pulling the breath into the diaphragm, and therefore we're not oxygenating our visceral organs as well as our brain. And our brain takes this as it's almost like our brain is saying, stop, I'm hyperventilating. the brain isn't getting enough oxygen. And so the brain sends anxiety symptoms, and we have a very difficult time with those anxiety symptoms. So once we learn how to pull the breath from our chest into our diaphragm, we really help to reduce anxiety and shut down that sympathetic nervous system response.
Great. And breathing might be the response that you're going to give to this next question, but it is, I never had panic attacks until being diagnosed with MS. What is the best way to deal with panic attacks?
Yeah. So panic attacks, I think we first need to understand the etiology as well as maybe what's triggering those. So we use a lot of cognitive behavioral therapy in managing panic attacks. So first we have to understand what brings about the panic, and then what's the thought that comes. So whatever that person says brings about the panic, there's usually an irrational or dysfunctional thought that comes right before that, and then that causes the panic. So it's important for us to really dissect the thought process. And this occurs over time, too, because people usually can't identify that thought process. And then we're able to, once we can identify that, help them to restructure their thoughts and then provide stress management techniques such as breathing. But there's also a very good skill called mindfulness that we utilize to help the person stay in the present moment. So typically with panic, somebody's going to a worst case scenario. And as Mark Twain would say, typically the things that he worried about throughout his life never came to fruition, and that's what we try to teach with panic. So we try to help people to understand the here and now, which is mindfulness, and to help them to stay here instead of going into the future wherever that fear may be.
Okay, thank you. Here's another question. I know exercise is helpful to fight off depression and anxiety, but when I exercise, I experience extreme fatigue and neuropathy in the ankle and feet area. Do you have any helpful advice on this?
Yeah, so one of the things that our physical therapist would say is, have you explored all forms of exercise? So many people think that exercise is, simply running or lifting weights or something really intense, and exercise does not have to be that. Exercise can be movement, and movement can help us with fatigue. So believe it or not, it's helpful to incorporate exercise to help decrease fatigue. So some of the things that we would suggest would be possibly yoga, not hot yoga, but maybe restorative yoga, or finding a pool that one can cool their body temperature, core body temperature, and maybe walking. So maybe doing things that aren't so strenuous, and that will be helpful for the individual and will help actually with fatigue management. It also helps with mood management. In fact, I can share for my fellowship, I did a study. The study that I did for my fellowship was looking at exercise over the course of 30 minutes, 3 times per day. And so we had individuals on doing a real slow walk on a treadmill and 10-minute spans. And what we found were that even these really slow speeds, so the speed that we took people up to was 3.2 miles per hour, which is about the speed of a bride walking down the aisle, significantly reduced anxiety and depression, so in only 10 minutes. So I thought that was a really powerful study because it showed us that you don't have to even do the 30 minutes all at once. You can do them throughout the course of the day.
Yes, absolutely. If anxiety is treated with medication and counseling and is well controlled, does it still increase cognitive decline?
No, if it's well controlled, it should not.
Terrific. And we're running up against the hour, so I want to ask one more question and then give you an opportunity to provide any last-minute suggestions or take-home messages to our audience. So the last question is, how do you know when it's necessary to seek professional help?
Yeah. So that's a question that I get asked very frequently, and what I would say is when it starts to impair your functioning. So when you notice that you're depressed or anxious or irritable and those start to impair your functioning, it's very important to seek mental health care. Also, when you're withdrawing or when you've lost interest in things that you once enjoyed, seek mental health care. Again, MS steals so much from us. Don't let it steal your joy.
Absolutely great information. And again, any last suggestions or take-home messages for our audience tonight?
No, I just really appreciate you guys joining. Thank you, Dr. Kaplan, for that question. For me, for me, the normalize and not stigmatize is just really something that I'm so passionate about. And I hope that all of you on here realize that it takes a very brave person to talk about mental health issues, but it is very normal in the MS population to have mental health issues. So again, if you find me on Twitter, I'm at Dr. Amy B. Sullivan, so DrAmyBSullivan, and we talk a lot about normalize, not stigmatize, and MS in mental health care.
Well, that's great advice. Thank you so much. Well, that does conclude tonight's webinar, which, as a reminder, will be archived to our website within a few days. Once again, I would like to thank Dr. Amy Sullivan for her time here tonight and helping us better understand and manage depression and anxiety in MS. I would also like to thank Biogen, Genentech, and Sanofi Genzyme for supporting our new virtual display hall. As mentioned, MSAA has additional programs on our theme of improving mental health and wellness, so please visit our MS Awareness Hub at mymsaa.org to learn more. And finally, we ask you to take a very brief survey that is coming up next. Your feedback is very important to us and will help us secure funding for future programs. So on behalf of MSAA and Dr. Amy Sullivan, thank you so much for watching, and please stay safe.